Okay, let me introduce myself. I'm Dolores Mitchell. I'm the Executive Director of the Group Insurance Commission, and that's the state agency that provides health and other benefits for Massachusetts state workforce and 30 or 40 municipalities and some, but not all of the authorities, and we cover about 425,000 lives, which makes us the largest purchaser of health care in New England. So remember, I speak as a purchaser. Let me also say, by the way, that as an aside, I want to tell you, I do a fair amount of public speaking, and it's interesting to see what organizations' leadership take good care of their speakers and are helpful and give them good directions and tell them how to get to the meeting and so on. Allison is an A+. Secondly, I want to thank you for giving me the opportunity to see Steve Tolman. I used to see a lot when he was up at the State House, and Steve, we miss you. And it's good to see you. And I want those introductory remarks stricken from my time. Okay. Let me tell you. The other thing is I have the dubious honor, I think, of being a speaker on this panel and on the next one. So if I don't say anything, it's not because I don't know about it. I'm saving something for the next session. All right. Anyhow. I've spent about 25 years of my professional life deliberately refusing to learn how Medicare and Medicaid work, and with good reason. And I think my avoidance was well taken because it finally caught up with me, called the Patient Protection and Affordable Care Act, AKA Obamacare. But I was and still am a supporter of the Affordable Care Act, even though I know from somewhat different perspectives what its flaw is. And I have to tell you, I've been a little surprised at the first few minutes of this meeting. I thought, oh, wait a minute, is this the Chamber of Commerce? I thought it said IBEW outside. I did not expect to see the level of negativism about the Affordable Care Act that I'm hearing today, and it's instructive for me. There's a line from the Canterbury Tales in which somebody says, "And gladly would he learn, and gladly teach." Well, I'm learning a whole new set of facts. It's very interesting to me, but I have some at least initial thoughts about it, which I will share with you. I was reminded of a big national kerfuffle years and years ago. You're all probably too young to remember this. When Charlie Wilson, who was then the CEO of General Motors, was pilloried for having said what's good for General Motors is good for America. I could kind of rephrase that to say that about the Affordable Care Act, that what's good for America is also good for the Commonwealth of Massachusetts as well, but some parts of it are more good than others, and that's what we've been talking about here. So, as you know, I also have the dubious honor of being a board member of the Connector, and we're struggling is hardly the word, we're having a heart failure over getting that exchange to work. We used to call it the Connector, and it's now called the Exchange. And it's been a very bumpy road, retrofitting the Connector, which was very successful. It's kind of a classic example of no good deed goes unpunished. We were the first to say everybody should be covered. We were first to provide a mechanism to help make that happen. And then the feds got into the act and ruined the whole thing and said, we're going to copy most of what you did, but we're going to do it differently, and you have to redo everything you did. And I also have to say, and this goes back to my opening remarks, that the level of detail in the federal regulations is enough to make a strong man, or in my case, woman, weep or scream or both.
Try reading them all.
Yeah, right. No, never. But to cover preventive care visits at no cost to the patient, and to limit out-of-pocket costs, these are benefits, and I think particularly for other parts of the country, but for here as well, but for a somewhat different reason, which I'll get to in a minute. And actually, we do not forget that a fair number of federal dollars have flowed into the Commonwealth as a result of the Affordable Care Act, and we even at the GIC got a few of them. Damn few, but a few. In any case, the expansion of Medicaid, you cannot ignore that as a benefit. There are an awful lot of people who were not eligible for Medicaid coverage before and who are today. And even some of those states that refused to cover Medicaid or to expand Medicaid until the Supreme Court told them they could refuse have had some second thoughts. But you're absolutely right. The Affordable Care Act did add costs to the GIC, and those costs did, in fact, end up in the premiums for 14, and they will again for 15, just as we're trying as hard as we can to keep premiums flat. It's hard to figure out exactly what the cost of those fees were going to be because, as you said, Karen, the federal government was not ready to tell us the details about how that was going to work. And they do not move with the speed of summer lightning when it comes to issuing what they call, and this is language you're familiar with, but I mean it just drives me crazy, issuing what first they call pre-rulemaking, and then advisories, and then guidances, and then my favorite, interim final rules. I think that's a contradiction in terms. And then final rules. In the meantime, of course, the plan's predictions of how much they wanted us to agree to let them add to the premium for those extra fees and taxes were all over the lot. We think that overall, when it's all balanced out, maybe 2 to 3% you could attribute to the ACA. And some of those costs are going to go down, and some of them are going to go up. And I am willing to bet a fairly substantial amount of money that the Cadillac tax is going to go away. But I think you think it's possible as well.
Ooh, no, I don't know. I mean, there's, we've got a Republican bill in the Senate proposing repeal. And we'll see. I mean, there are pundits and health folks who are predicting that, but unfortunately, I don't think we can rely on that. And if people are bargaining today for something that's going to slip into 2018, we may have some options, but I don't think you can count on it going away.
Maybe postponed. Anyhow.
Hey, you never know. There's lots of postponing going on.
Anyhow, those of us who are in the healthcare business are learning to love, or at least live, as a partner with the federal government. In the meantime, we at the GIC, and I think this is what I was supposed to be talking about, are continuing to do our own thing because the concerns that we've been struggling with for years are still very much with us, and the ACA is not going to solve them for us. We have to solve them for ourselves. We're still trying to get our arms around the cost monster, and we're still trying to prod, push, motivate, and even threaten providers and payers to make the fundamental changes in the delivery system that have been talked about for years but have yet to go into practice. And this is where I do have a slightly different take, because I think to blame either the bill or the evil insurance companies really takes your attention away from the nature of the problem, which is the cost of health care.
It's prices.
It's prices, and it's not the cost. Thank you for saying that, because everybody says this is what it costs. I know that's what it costs. It costs too damn much, and that's what we're trying to change. So, there's a lot of talk about how things are really changing, and the providers are saying, oh, we're doing a better job of patient safety and coordinating care, and they're beginning to talk about the virtues of community hospitals. But when push comes to shove, the basic change, the basic changes about who gets paid, how much, and how is pretty much still the status quo. Hospitals still do not share data. Fee-for-service is still the predominant payment method. Preserving or even maximizing revenue still prevails. And it's at the same time that people don't have primary care doctors, and the cost for patients and for the purchasers, you're paying for them, but so am I, so are you also as taxpayers, are still going up. So there's plenty of work for us to do, and we're trying to stir things up, pushing our plans to accept financial risk. You can translate that into financial penalties for staying inside of budget targets, and we're requiring them to drive better bargains with their provider contracts, instead of just passing on to us and to you whatever those provider groups say they want or need. And we insist that those contracts have to include better quality measures, not just less money, as well as better service, better hours of operation, and better prices. And there, where financial risk means if you can't or won't control your spending, you're going to have to eat the deficit. That's what we're trying to change. So, the ACA and our own Massachusetts Chapter 224 share these goals, and they help create a climate of change. But cultural change, and it is a cultural change, is very difficult and very slow. But there's never going to be a better time to push for change. What our job is at the GIC is to try to push the pace of change. In the long run, we hear things will get better, but I say we need action now, not in the long run. Let me end by saying, we do not, make this very clear, we do not intend to lower our costs at your expense. We do not believe in high deductibles. I know we have some, but they're the lowest in the country. But we do believe that doctors and nurses and hospitals are perfectly capable of giving you and your families excellent care for less money. We believe, or at least I do, that the goal of labor justice, I looked you up on Google to see who I was going to be talking to, the goal of this organization. And we think that your goals can be better achieved if resources of time and attention and money are made available for you to pursue those goals. But your members, this is the bottom line, your members need to believe that the health of the Commonwealth, as well as the health of their individual families, is at stake in pushing for payment reform. What we're calling for from the medical world is very broad change, calling on their leaders for vision and courage. Support from labor, asking for that change, demanding that change, asking the leaders of the medical professions and the government to just get on with it, could make the vision become a reality. Thank you.